So we heard incredible lecture by Bob Bono about some of the medical management of sort of Lp(a) and targeting the ventricle. And we heard from the fantastic impact that I think our cardiac surgeons are finally waking up that they better get to it. And I think they are, and working hard to improve outcomes. And you can see that on the transcatheter side, it's just a constant development in improving outcomes and constant clinical trials. How do we put all of this together as we look to the future? I was sitting next to Antonio Colombo as Bob was speaking, and he's going to write a viewpoint for us, I think, Bob. I asked him to, because he said a profound thing. He said, and I think as someone who's really been the father of interventional cardiology, for him to say this, I think it's quite significant. That maybe interventional cardiology and transcatheter techniques have sort of dominated now over surgical valve replacements, and maybe you can respond to that. But he believes that the future medical management and earlier prevention will probably prevail and overpower the interventional and transcatheter approaches. Now, Bob, you might like that as sort of that's sort of how he's seeing the future. But I'm wondering how first Joanna would respond to that, and then Lars, and then finish up with what Bob might think.
That's a big question. So, you know, if you'd asked me 5 years ago, I'd have said something about high quality evidence, randomized trials, thoughtful guidelines, physician education would drive practice in the right directions. It manifestly does not. There are many reasons for that. It is really difficult to design randomized trials so they truly inform practice. We've written extensively on this. I co-chaired one of the, I think it was an ACC or an AHA scientific statement on the challenges of designing and executing and reporting randomized trials in this space. That said, it's essential. If we're going to do it, we can't depend on our industry partners to design and fund them for us. Most of the trials that you've seen presented today are designed, run, reported by the manufacturers of the devices, and that is not a platform that gives you, oh, lost my finger there for a moment, data. It gives you helpful data, but it doesn't certainly give you a clear picture. And I think that the sad state of the NIH funding, that means that the money for this is sort of coming out of an increasingly small spot. We have to advocate more strongly. And one of the reasons I'm excited to be more involved with the AHA is that compared to the SDS, which has, I don't know, $30–40 million in its bank account, the AHA, I think, earned close to $1 billion last year. $1 billion. And spent about 27% of that on research. Now there's an engine for informing practice. And one of the most meaningful sessions that I went to at a cardiology meeting, which in fact was ACC, is we designed it specifically to have a discussion between non-invasive, interventional and surgical colleagues about patients that fall in between. The room was packed, it was standing room only. People have a huge appetite to learn really how best to manage these patients. And then finally, ultimately, patients will drive this, and the onus is on us to make sure that they have the right data. With Google at their fingertips, they will. And if we don't get our house in order, CMS coverage determinations will drive practice, and that would be a shame.
Oh, thank you. Lars,
yeah, but
your response to that?
Yeah, but I agree that I think the good thing about transcatheter heart therapy, that it certainly has made a change. A lot of patients are now treated and have a much better life and longer life and better life quality than it had just 10–15 years back. And it's been driven a lot by evidence, but we've also seen that at least here, the recent years, that the trial has been designed by the companies. It's been very selected patient going into it, and still opening up for a much larger patient cohort And I think we need independent, investigators to design and execute these trials. I just showed you one example. You saw despite the evidence and the guidelines, TAVI is just working its way to much younger patient with bicuspid valve, which had never been studied. So I think we have a responsibility to make these trials, and also the surgical community should also push back on this move forward and try to see we cannot replace, as you demonstrated, high quality surgery at a very low risk, very efficient, with something we don't have any evidence on.
I'm happy to be over discussed by the catheterization group. Lars makes a really good point, but I saw it also in Joanna's data as well. But getting back to Antonio's comment, yeah, I think if we are talking about earlier intervention, based upon whatever evidence we get that we should be proceeding earlier, then we're going to be getting into younger individuals. And so this point that Lars made is really important. And Joanna, I was impressed also by the data you showed, I guess not yet published, regarding the decline in surgical repairs for degenerative disease, with this marked increase in TEER in those patients, and yet TEER for degenerative disease is only supposed to be for really high-risk patients. Who's keeping track of that?
And then we go down.
Can't that be controlled by who's getting reimbursed, and whether there's really a heart team approach to indicate who really is a candidate for TEER?
When you look at
Yes,
CVT
that's right.
data, and I guess that's who's keeping track of
When
it.
Malcolm is in the room, he sees her
60% indications for TEER in low-risk patients with STS, less than 2% predicted surgical mortality, is frailty, and 30% is unusual circumstances. So 90% is just a grey call.
Yeah.
Fantastic.